Good afternoon, everybody. My name is Wallis. I'm the lead for emergency care at the headquarters of WHO in Geneva. I'm so sorry I'm not with you today. If you saw my other talk, you'll know I'm on safari in Botswana with my family. It's annual leave time, school holidays. So many apologies and good luck to the whole of Mascot Organising Committee and the speakers and participants in what I hope is a very successful conference. You will have Vanessa Naidu from our team in the question and answer session. I'm sure she can address any issues, but we do have an email address at the end of the talk so that you can reach out if there are any questions. So within headquarters, there's the World Health Emergency side, and then on the other side, dealing with the more sort of day-to-day systems, we have universal health coverage, and there's a couple of divisions there. We're in universal health coverage across the life course, UHL. And then we have a department focused on integrated health services. And in there, you'll find units on patient safety and quality of care and infection prevention and control and health service management and so on. And our unit, clinical services and systems. And you can see we really about how you integrate and organize care delivery, the actual first contact in many instances. But the clinical care provision. So we focus on how care should be structured, the sort of models of care, the packages, what should be provided where, the pathways, how you move up and down the system. And then primary care, that happens in a clinic setting typically. Emergency and critical care, that's my remit with my little team. And operative care, surgery and anesthesia. And then we have these cross-cutting modalities on trauma, and sepsis care, on palliative care, and then integration of hospitals. So that's just to frame where I'm coming from. In the emergency care work, we look at how the emergency care system should be set up, what should be provided where, for instance, what emergency care services should be available at a primary care level. So if you are injured and you present to primary care, what should they be able to do? Therefore, what equipment should they have? And what skills and knowledge should the healthcare workers there have? And how should you then move from primary care to a facility? So referral networks and care pathways. So we go from community, we have a lot of focus on how communities can effectively respond and what they should be able to do, all the way through to significant overlap in mass casualty management. And then, for instance, as we saw in COVID, both maintenance of essential health services for those who are not affected by COVID directly, but are affected by the emergency and that their care access is changed, or for those with the primary disease of concern, which often, so with COVID presents as an emergency, with Ebola presents as an emergency, with earthquakes presents as a trauma emergency, and so on. We conceptualize the emergency care system in three parts. So care at scene, care during transport, and care at the healthcare facility. So at the scene, there are certain things that we have agreed to extensive consultation that should happen. For instance, you should be able to phone someone and get advice while a trained professional is coming to your assistance. You should really also be able to access a trained first aider in the community. So that follows all the way through to the healthcare facility, including early operative care and inpatient critical care. Now, when we look at systems across the countries, and we've done that in depth with the ministries in over 50 countries now, when you look from the community all the way into the operative and critical care components, we find common issues and common gaps. And then ministries of health ask us for support in terms of developing tools to help them. So we have a very comprehensive set of tools for ambulance services, for instance, working with the emergency medical teams group, that's the EMT system. We have a number of tools and training materials around mass casualty management and surge coordination. We have, as we'll spend some time on now, standards for quality and data. We have a lot of training materials and even more coming out now, centered from the basic emergency care course, which some of you may know, but many others as well. A number of protocols like the interagency integrated triage tool and our clinical checklist. And then legislation and policy tools, and a lot of similar work on critical care and operative care, and upcoming on primary care. So this is how we think about the products that we produce to support health ministries in countries. So one of these is around data, and we used to call our registry the International Registry for Trauma and Emergency Care, IRTEC, hence the picture, but it's now called WHO Clinical Registry. And I'll go into detail on that now. But this is one of our tools that has been identified repeatedly by countries as a gap. They don't have data and they don't have quality improvement processes in place in emergency and trauma care. So why do we do this? Beyond the fact that countries don't have it, what is the point? Well, I'm sure you know, sorry, I'm not sure who's in the audience, but most clinicians get taught this these days, that quality improvement, it's a method for improving clinical care by looking at what you did when a patient presented, what decisions you made, what actions you took, where there are gaps in those actions and those decisions, and then identifying corrective actions to avoid, let's not even say poor outcomes, but to avoid less than ideal outcomes. So you're really trying to continuously improve quality. So you're looking at care of patients who are either pre-selected for certain reasons, or you're just choosing, I don't know, today we're going to look at head injured patients, for instance. You look at the data that's available from your system, you identify problems in the care that were delivered, and then you look for factors that led to those problems, and you develop improvement plans, which you then implement through this. You know, we used to have this, I'm sure many of you have seen a PDSA cycle, Plan, Do, Study, Act. Now, our quality of care team in our department have refined that to be, it's still basically the same. The two sections in the top right, the sort of 12 o'clock to 3 o'clock section, are about planning and then doing and then studying and then acting. So it's the same iterative process. You just keep going round and round this circle. So any quality improvement activity, you start with your aims, your plan, what it is that you want to do. You identify the gaps, you choose the relevant standard that you're aiming for, and you develop action plans and implement them and measure the change that's happened. And of course, you need data for that. So quality improvement programs have been shown to be practical means to achieve improvements in clinical care, and they're cost effective, and they can work anywhere and everywhere. They really enable us to look in depth at what we're doing. And if you do them well, then you should have buy-in from all of the clinical team, not just in your unit, if you're working, say, in the emergency department, but these should be cross-departmental processes as well. So you really get buy-in from across the health system, either just within your facility or ideally involving the pre-hospital services and, where relevant, primary care as well. Again, our quality of care units produced a really solid quality toolkit, which you can find on WHO's website. This is one of the sort of foundational diagrams or illustrations that underpins what we're doing with quality. So there are 5 foundational principles. So that's on-site support with education and training, standardized data collection, which is what we're doing with the registry, and that allows you to track the quality of service delivery. Knowledge sharing and community and stakeholder engagement, and then effectively managing to make sure that the programs are carried out with the necessary support and that any recommended changes can be introduced. So the part of the problem is that there's really a lack of critical data on acute presentations, particularly for the purpose of today's talk on trauma. It's unfortunately pervasive across the whole of acute care, but certainly there's not adequate data on acute trauma presentations, and we see that trauma data often is focused on the epidemiology. So that people have falls, or that they have road crashes in this particular intersection, or that speeding is a cause, or alcohol is a cause. It's the epidemiology. There's very little on what do you actually do with patients when they arrive at your health facility, and that's what this trauma registry module is trying to close that gap, so that we can really understand the needs of the population in terms of injury care. So, in terms of the WHO clinical registry, I will go into a little bit more detail, but we have from 2018, and the rollout was significantly interrupted by COVID, but we have a trauma module. And now we're in the piloting stage of an emergency care module that I will show you. And there's upcoming very soon an operative care module for surgery and anesthesia, a primary care module, sepsis, and eventually a critical care module. But the same principles apply for all of them. So you need some standardized documentation. This may be an electronic patient record. It may be your existing paper record, or in places where the notes are poor, and we see this a lot, the notes are blank pieces of paper that have the patient's name and date and say road injury, head injury, sutured, discharge. The note standard in many places is very low. So we recommend this. If you don't have something that's suitable, then the standardized clinical form. I'll show you a little bit more now. Then if you're talking about the trauma registry, we have a data set for injury that was developed through consensus process, both through the Global Alliance for Care of the Injured and an Epstein process, and the same for the data set for emergency care. And then we have the registry platform. So starting with the first part, the clinical form. So our clinical form, and of course, if you have something that already meets this need, then that's fantastic. But our clinical form is intended so that it can facilitate care delivery. So it's written as an ABC. And we found when we studied this in a low resource setting that without introducing any other change, if you just introduce this trauma form, which is 2 sides, 1 piece of paper printed on 2 sides, the clinicians have to start recording their notes as ABC, and therefore they start thinking ABC in their approach to the patient. So even without training them, we found that their behavior changed, and they took a more logical ABC approach to patients, which obviously ultimately is what we want, because that improves outcome. So we have this quite tick box focused standardized chart, which first of all allows for simple note taking and, like I say, drives clinicians to behave in an ABC manner, but secondly maps to the data sets. So it allows us to enter into the registry platform more easily. So the data set for injury is the minimum set of data elements. So this was derived through a consensus process, as I said, Global Alliance for Care of the Injured, multiple iterations of global inputs. There are 46 data points that should be collected on every trauma patient. And then there are 28 that form this extended set. So there would be a total then of 74 if you collected both core and extended. All of the core variables are embedded into the standardized form. So you'll see, for instance, in yellow, these are pieces of the puzzle that get entered into the clinical registry. So on the trauma form, these yellow components are core, the 46 core components of the data set for injury. And then many of the extended are already in there. But again, if you have a standardized form that's already in place and it collects these data elements, then you're in a good position. You wouldn't need to change. If you're missing some of the core ones and you wanted to introduce the registry and capture just the core data set, you might need to make small changes to your existing medical records. And this is what, it's not just about using a PDF from WHO and printed it out. Sometimes countries take it, look at it and say, okay, we like the idea, we're going to standardize it for our own use. It certainly doesn't have to be used in that black and white process that I just showed you. So this is the standardized trauma form. the non-trauma form. So there's one for trauma and one for other emergencies. This is the non-trauma form in its two-page version, as rolled out nationally now by the government of Nepal. So every emergency patient gets this form filled out, and it maps perfectly for the trauma form to the dataset for injury, and for the other form to the dataset for emergency care. Okay, that is the essential component of setting up the trauma registry. So standardized charts to make sure that you capture the record, the data points on your clinical record, a mechanism to enter the data, so a data set for injury, and then a platform to put it onto, which is the registry, and in this case would be the WHO clinical registry. I'll just step back a second and look at what's the sort of push to roll out. And in my other talk, I've just mentioned this a little bit as well. We are driven by our member states in our World Health Assembly. So it's the mechanism by which we are given our work mandate for the coming years. And in May this year, this resolution was passed, 76.2. And it, amongst all of the many activities that it tells WHO to do, we should provide a platform for data entry, aggregation, and analysis and feedback. And member states should collect standardized data and should use it both for system design and for quality improvement activities at individual hospital level. Okay, so we have the dataset for injury. We now have a dataset for emergency care, which is for all emergency care presentations. It includes all of the injury care variables and then some core or essential variables for monitoring emergency care more widely. So for instance, it has triage details in there. It has information about chief complaint beyond injury, and it has some pre-hospital components. Looking a little bit more widely at the registry, the dataset for operative care is coming very soon. So the operative care module will be launched soon. So then you'd have the trauma module, the emergency care module, and the operative care module. So that contains the relevant injury variables plus essential variables for monitoring the quality of operative care, so both surgery and anesthesia. And it has 39 variables, 13 are existing and 11 new from the 24 core variables. So how do you use this detailed registry to actually improve quality of care? Talked a little bit about quality improvement activities and a little bit about the registry, or a registry. I'm using WHO's registry, obviously, as an example. So you'd want your registry to have built-in analytics, and the WHO registry does. So it has the data entry component, it has dashboard of visualizations, and then it has analytics. So you, as a user, you would be given for your facility some standardized reports back at the push of a button. So it uses case level data to identify potentially preventable deaths or bad outcomes. And it can integrate data from across the patient's journey, from pre-hospital through referral hospitals through to the inpatient component. So back to these pictures again, on the left, the picture you've already seen about how quality improvement activities actually happen. So you in this sort of 1 o'clock position there in the top right of the first picture, you gather data and monitor the system, and then you analyze for preventable deaths, or if it's not deaths that's the interest, if it's bad outcomes, other bad outcomes. So you look for those and what can you do to change things. So if patients come in so severely injured, that's not a preventable factor. But if they come in and they have a poor outcome because, for instance, their hypoxia wasn't recognized, their tension pneumothorax wasn't recognized, their shock wasn't recognized, then those are preventable factors. So you analyze the findings and you develop corrective action plans, you implement them, and you gather data. And you do this in the red and green picture, the closing the loop. You introduce a change, you measure again. You see if it's got better, you introduce another small change, you measure again. So we have data on patient presentation, on the care received, and on their outcome. and then we want to see if poor outcomes are preventable, and then we feed back to the clinical teams, and we have targeted changes in the system and targeted clinician intervention through education. So we take corrective actions over time. Now, one of the ways that you can identify the patients, of course, is to select. You may know from your department that we have a series of bad outcomes in head injured patients, therefore we should look at that. We've had more deaths from road crash recently than before. Maybe there's something going on, so let's look at road. So you may use your own knowledge to identify which cases to look at. You may use patient complaints to identify that. Clearly, in many cases, that's not death related. That's some other bad outcome. Maybe they waited too long. Maybe they feel they didn't have adequate standard of care. So patient complaints are often used as a way to identify patients for quality improvement activities. But if you wanted to, you could build into your trauma registry a series of audit filters, and we have that in the clinical registry, where there are predetermined filters where you could identify patients who you should look to see if there are system or provider level interventions that can be changed to improve outcome. So one might be, these are straight from the registry. So failure to rescue. So the patient is perceived to be low risk, but dies anyway. The patient has a low conscious level, so GCS less than 9, and needs an airway maneuver, but didn't get it. Patient is hypoxic or tachypneic and didn't get oxygen. Now, of course, you may look at some of these patients and find that they actually did. It wasn't recorded, or it was recorded and it wasn't entered into the registry. And of course, then they are not for quality improvement activities necessarily, although I've always found that just taking random patients from presentations, you can always learn something from their care. However, for the audit filters, we're assuming that these are patients who genuinely had a need and genuinely did not receive the intervention, and it's not just a recording issue. So patients who are shocked and didn't receive intravenous fluids, patients who died in the emergency department, patients who were triaged to one of the lowest categories, let's say green or yellow, depending on what system you use, and ended up in the intensive care unit. So that's obviously a mismatch. Patients in the highest triage category, so usually that would be red, depends again what system you use, who then wait for more than 30 minutes to see a clinician. And patients with a low blood glucose who did not get glucose. So these are all fairly obvious interventions that should happen that may not have happened for a variety of reasons, either system related or provider related, and make for very good and easy to identify quality improvement initiatives. So here would be an example from the registry. This is a dummy data set that we use to generate these screenshots. So we're looking at patients with hypoxia who didn't receive oxygen. So let's say we did this over a 3-month period. So it's the last quarter. We pull all of the cases. So you plug in the time zone that you want to look at, the last 3 months, and the registry gives you the patients who you should identify their folders and you should review them. Now, as I said, in some of them, you'll find that actually it did happen, it just wasn't recorded into the registry. You can put those folders back, and then you'll be left with a pile of cases who need review because they were hypoxic, and for whatever reason that you're going to look into, they didn't receive oxygen. Here's another example. This is patients who died in the emergency department. So audit filters, very powerful mechanism, very easy and inbuilt into the WHO clinical registry. I mentioned a couple of times there are dashboards. So here's a couple of the dashboards. I know you can't really see them very well, but these dashboards can be modified depending on what you want. And for instance, the ministry personnel who are looking at multiple sites will see different visualizations to you for your own facility. So the sort of standard data visualizations that you would get would be cases over time, mortality over time, mortality related to the injury mechanism, For the ministry, they might see across different facilities what's the spread of severe injuries. So maybe one facility is getting a lot more severe injuries than they expected at ministry level. So then you might need to switch the way that resources are allocated, or you may need to change the referral pathways. Number of patients with severe or moderate injuries, number of records completed within 2 months of discharge, demographics table, and then mortality by severity level. So we do have some injury severity scoring built into the registry trauma module also. So here's an example, Kungkan Hospital in northern Thailand. So in the mid-1990s, they introduced a trauma registry because they knew they had a growing problem of trauma. The initial quality activities showed that there were a high number of potentially avoidable deaths. So they set up a trauma audit committee, and they identified as their sort of target in the first place, in the first few rounds of this, all patients who died, having been admitted with trauma at the hospital. Many issues were discovered, both in the system as a whole, as is often the case. The system design is often responsible for poor outcomes, and at the individual clinical care level as well. Then they took appropriate corrective actions, and the trauma registry was able to show improvements through time, through improved compliance through these medical audit filters, and they were linked to decrease in mortality. So the original mortality in the first analysis was 6.1%, and it fell by over a third to just around 4% over time. So these are really powerful mechanisms to really improve the quality of care. In my other talk, we talk about how to sustain implementation and the sort of steps you need to go through. But if you do it well and you use the quality improvement mechanism through sustainable and through mechanisms that the clinicians buy into, then you really can impact on patient outcomes. I hope you found that useful. Again, if you want to sign up or find out more about the WHO Clinical Registry, please just scan this QR code. And if you want to reach out to us in any way, please drop us an email here for any questions about emergency, trauma care, critical care, the registry, any of WHO's work. And Vanessa will be on the Q&A session and happy to answer your questions. Thank you so much and good luck with the conference.